Thank you, Dr. Boramani, for this opportunity, and friends, Satish, congratulations for this innovation. And Satish is a person who practices not in the megapolis, he is from the periphery. So similar kind of talents, many of you must be talented like him. We want a lot of innovations, and you saw Boramani innovations, and then you saw the smart incision, and we want many more things to come from all of you. So my job is theoretically, I think Divya has spoken about the astigmatism with the rules and against the rule, and all of you know that in astigmatism it is not coming to a point of focus, thereby giving astigmatism of different kinds. And so theory I will not focus, but my experience with doing this surgery, what I want to share with you, that people are expecting in very good results, and you must give 6x vision. And one of the challenges was that can we be like the phaco surgeons, whether we can elevate ourselves to that level. Earlier the surgery SICS was very messy. When you do cut it like nobody's business, nobody wants to repeat that kind of surgery. So now what we are doing, I am doing, which I will be sharing elsewhere, the 3mm SICS surgery, for which I have modified a lot of instruments. And with that, if you see the next day cornea, it is crystal clear cornea, and the result is I am studying all the I have with me the NIDEC auto-refractometer and Topcon also. I have lens star with me, and topography, everything. See what happens now, we have to know what is the pre-existing astigmatism. We generally don't record properly. SICS, all SICS surgeons must become more micro-focus than what they are considering themselves. Chalta hai, chalta nahi hai. We have to elevate to a world class, and everything detail has to be recorded. Okay, what is the astigmatism, and find it out, note it down, and then when you measure and compare with different instruments, invest a little on these things. It will help you, and you will enjoy yourself. That pre-assessment is a must, and incision characteristics like size, and Divya has already spoken on this thing. I don't want to repeat them. And whenever you are recording these things, see that somebody really carefully recording the the K readings and everything. If it is a novice, don't pass on that responsibility to the novice, because there will be a lot of difference in the result. Either you do it, or somebody who has been trained by you should do it, so that the result can be really proper. And what I do is, before taking the measurements, I put the lubricant so that the tear film don't break down. Even the tear film breaking down also will give a difference of results. Sometimes I compare with the manual also. I find whether it is okay, but manual I think you should overcome and go for the auto refractometer, and I find NIDEC is a very exacting instrument. It gives me very good results. So I depend on that. Keeping when you sitting position, you can mark the 180 axis. That will be a good thing. See that the patient sits straight. Many a time they bend down and all those things, and that will have a wrong reading. And the lead sometimes covers. Don't do that. Try to see that the lead is fully open when you are taking your K readings. Small points, but they have a long. They affect your results. Now, many a time when we are doing the temporal things, now, if you are not good with your practice, then it becomes difficult. So you have to have master the practice, using of the practice. And you see this topography pre and post operative. So they hardly, and this is the first case, the astigmatism hardly anything, it is reduced rather. Second case also you see, it was from 0.39, it has become 1.6. And lot of studies I am doing, and maybe in the other conferences I will be sharing my results. And she has told that the length of the, all of you know that if the length is more, and then the astigmatism will be more and same, and if you take it the incision little behind, by maybe up to 2 millimeter behind the limbus, your astigmatism will be less. And if you follow Boramani's things and make it more curved, you can have a measured astigmatism. And estimating funnel, all of you know, I don't want to repeat that. Frown incision is the standard incision, and now Boramani is taking that you have to make it a more shorter and U sort of incision. And scleral sinkage, then Divya has covered that you don't have a ballpoint cautery. If you do it by this wet field cautery, that and just erase it, don't try to, the moment you touch it more, and then it will be, it will create it will affect your astigmatism. Now, length, depth, and tightness of the suture she has covered. Then, so the astigmatism thing, we are really working very hard on that. And as a SICS surgeon, you can feel proud. You try to become more scientific, more micro-focus, and you will find that a lot of people will learn from you, from your innovation. As Satish Shet has given us some innovation, we are looking forward to more bright SICS surgeons. Thank you.